So, so I'm a physical medicine and rehab doc. I'm sometimes called a physiatrist and sometimes called a physiatrist. And my view on rehabilitation probably coincides with the panels. It works better if there's a team. My specialty focuses on function. And in terms of someone who's had transverse myelitis, there's going to be kind of a couple different components of the function. One is the medical treatment, which has been discussed a lot. The second is the activity that the person is doing and the activity the person wants to do. In that pathway, there's exercises and stretching, but those have to be tailored to the person's ability and their potentials. And then there's also equipment. There's this, and the equipment that you use makes a difference. There's a difference between one cane and another, one walker and another, one wheelchair and another. You know, again, depending on your community and your resources, I think it's great to look for a therapist who's savvy about MS and about spinal cord injury, because those are the expertise groups that are common, that are most likely to apply to someone with transverse myelitis. I think it's also helpful if you can find a physical medicine rehabilitation physician who can be part of the team, because sometimes we have a broader view of things and can partner with the therapist better than the therapist working by themselves. If there's a good connection between the therapist and another informed physician of another specialty, sometimes that works. But I would also include the physical medicine rehab doc if you can find one.
I was going to make one other comment too regarding function. Physical therapists and occupational therapists have to have functional goals. They can't just do exercises or even activity-based therapy, riding a bike. They have to have functional goals, and so sometimes you have to help the therapist. So when patients come and see me, because I do a lot with rehab too, I always ask them, what are your goals? And it can't be necessarily walking, but you have to break it down into smaller steps. So if you are thinking about what kind of goals that you have, and even if they're small goals, they have to be able to have functional goals that they can reach, and step by step by step. And sometimes the therapists are just, it's hard for them to think of what they need to do. So you have to think with your loved one or your child, what goals do I have, even if they're little small goals that we can accomplish to get to that bigger goal. And that will really help sometimes with the therapist, because they're like, we don't know what we can do, you know. So I think that's important.
There's also a difference between exercise and therapy. I'm kind of echoing what you've said, is that if what you want is, if what the treatment's needed is for your loved one or yourself to be more active, that's not really a therapist's job. They're not the coach in the gym for you. Just as you said, they're focusing on where you are now and what is the intervention I can do to get you to a better place. But they are not the person that's constant. They should be working with you to have, again, typically a home exercise program, and then it's your responsibility to follow the program.
And that will pretty much help the comment that you made earlier, when you have a highly functioning patient, they go to a rehabilitation place where they get looked at and say, well, you look good, we're just going to send you home. I advise these patients to go there with very specific goals. They said, I can't do this specific task. Can you help me do that? And then they will get treated and they will get benefit from that. And they will not be sent home.
I've got a NMO-related question. I think yesterday, Dr. Levy said that 25–30% of NMO patients have some other autoimmune condition.
Autoimmune antibodies.
Okay. That being said, how does that impact your treatment choices, both in the acute phase as well as preventative?
In the acute phase, it doesn't change, because in the acute phase, they're pretty much treated the same, with one exception. I may be more amenable to cyclophosphamide early on if they have a good case for lupus overlap or a Sjogren's syndrome overlap or something like that. In the long term, for preventative treatment, it also turns out that there are a lot of overlap treatments. So, for example, rituximab and Cellcept, which are great for NMO, are also great for a lot of rheumatologic diseases. So we're safe treating for one or the other, but we always have to be cognizant that there could be systemic manifestations of lupus. There may be lung problems that need particular attention, or kidney problems in lupus, whereas for NMO it stays mostly in the brain in my clinic.
Does your thinking also include family history of autoimmune disease?
Ben?
It does. So, with NMO, there doesn't seem to be a family history, a predisposition. But with rheumatologic diseases, there certainly is. I often get an NMO patient who says, well, my sister has lupus, my mom has rheumatoid arthritis. And so when I hear that, I do think along the lines of rheumatologic diseases is probably going to be an overlap issue here.
Hi, I have just a couple comments. I also agree with the physiatrist that it would be nice if the TMA was updated, especially with and it may, in our panic, we haven't been there for 2.5 years, but we were not advised downtown Chicago to be released to rehab services. So we were just told to get therapy, and that was it. So if that could as well be updated. And then secondly, if there could be a pediatric section on the algorithm for those kids that can't say, I'm having this band around my chest when they're 16 months old, or, there's tingling in my feet. If there could be something for our physician who wasn't listening to me, that it's something in his spine, he's flopping around like a newborn. And, something that's signaling to those physicians the difference for those little guys that can't speak.
That's a great point. I have a 3-year-old actually, when he first presented with neuromyelitis optica, and I asked the mom, has he ever had trouble seeing things? And she insisted, no, never had any trouble seeing. But it turns out when we tested him, he couldn't see out of one eye. And, even the mom had no idea. The kid won't say anything, and for a long time, the mom text pages me. She'll say, my kid fell, and I'll say, check this, check that. And it's really hard to tell in kids because they won't tell you what's wrong. And even a problem for mothers to get this out of their kids.
Yeah, it's the physicians have to in terms of the algorithms and so forth, they have to be thinking about this, especially in the really, really young patient, kids who are under 5 years of age, because there are many more common things that could look like a spinal cord disease in under 5 years of age. I haven't looked at the website in a while, so I'll take a look at that with regard to pediatric information. But it sometimes is very difficult. You have to have a high index of in terms of, as you're going down the different diseases, you have to think about that as part of your differential. A band-like sensation in a 16-month-old. I mean, really, what we look for are sweat levels, honestly, for kids for spinal cord disease who really just can't tell us anything. So it has to, some of the things like that that are pediatric specific. Perhaps we need to take a look at the website and the algorithms and
No, I think it's a
clear.
really good idea. It's a really important thing that should be out there. One of us should take that task on of establishing essentially a pediatric algorithm, because it's different. I mean,
It is
the
different,
symptoms are
yeah.
different.
The symptoms are different. Our thinking in terms of
Yep. Right, but
Right.
and the spinal cord is different. The
Right.
spinal fluid is different. Obviously, the clinical presentation is different.
Right.
So there's a lot of literature about kind of what are the symptoms that kids with TM present, but to put that together into almost a practice guideline, an algorithm like that that we have for the adults, I think would be really important.
Yeah, as far as I know, the largest series has been put out by Frank Piddock at the Kennedy Krieger. So maybe Frank and I should talk about that.
Could I also say something to address your point? Because I think your reference to our website to be able to provide guidance to people who find this when you're really in the middle of having to deal with these issues. So know, if to the extent that you can, I always suggest to parents and to family members that if you can present a doctor with information that is in the published medical literature, you're probably going to get taken more seriously than if you say, I printed off some pages from the Transverse Myelitis Association website, because they don't know us from Adam, and you can print anything off the website, which is why.
Actually, I would say that I've had a lot of physicians from, at least in Kentucky and Tennessee, who have actually, gone to the website and have really valued the information they found there.
Excellent. But my plea to all of you and Ben over here is to the extent that you can provide us with the kind of guidance that we're talking about, I think getting the algorithm in a more prominent place is a great idea. I think we need to do that. I think if there was something, when a parent like yourself calls me and says, my child was paralyzed, they went through acute therapies, and then they got released home for outpatient therapy, I'm freaked out. I'm thinking, why did this child not end up in a rehab hospital? But I don't have any guidance. I can say to them, that makes me really uncomfortable. Would you please talk to your doctor about that? But I can't make a judgment for a family about, go get your kid into a rehab hospital. However, if I had something that was published by somebody up there who had guidance that with these sorts of deficits coming out of acute therapy, that people really need to be in a, taken to a rehab facility, that would be tremendously helpful. So that's my comment about that. Thank you for bringing that up.
I had a question on the chance of transverse myelitis changing into multiple sclerosis. There was a young girl in my community diagnosed with TM, very quickly taken over to Jefferson Hospital in Philadelphia, quickly had what they said was all the right things. The doctor right away knew it was TM. She recovered really well. Within 6 months, she was fine. She was walking, back to teaching. She was a very young girl, like 28, 29. Had a reoccurrence, and the doctor explained to her that, well, they probably didn't give her enough steroids, so she had a second steroid treatment, and she was great. A year later, she was diagnosed with MS, and I'm just wondering, as a TM person, should I be, or what should I be looking for, expecting from my doctor to make sure that, or what is the percentage of that? Is there a percentage of people with TM going into MS? And if so, how should we be taking care of ourselves to make sure that doesn't happen to us?
Well, there's always the risk of transverse myelitis being in the spectrum and end up being MS. And I think what is important is doing the spinal fluid initially and do the whole brain MRI, spinal cord. If we know that there's nothing else, just that first episode of transverse myelitis, at least what I do is just keep doing some follow-up over time, treat the acute episode, and then keep doing the MRIs and see if at some point the patient will develop MS, and then we can confirm that diagnosis.
Yeah, so at the point, and I'll put it to Doug, so when somebody with transverse myelitis presents, there are tests that can be done. So Wanda mentioned the brain MRI and the spinal fluid, and there's relatively good data based on those 2 time points. How concerned should you be in terms of this being a first presentation of MS? And Doug, I don't know if you want to run through the numbers.
Yeah, so I think you can explore a bunch of things right up front that can give you some confidence as to whether or not it ultimately will be multiple sclerosis. For example, the spinal fluid shows oligoclonal bands typically in patients who are destined to get multiple sclerosis. It's not 100%. None of these things is 100%, but they're kind of weighting you for or against. So oligoclonal bands in MS, but not in transverse myelitis. You get a brain MRI. In transverse myelitis, it's almost always completely normal. And in multiple sclerosis, most of the time, it's not completely normal. There are silent lesions that have been there. The MRI of the spinal cord looks very different. In MS, it's a small lesion around the edge of the spinal cord. In transverse myelitis, it's across the whole spinal cord. In transverse myelitis or neuromyelitis optica, it's a long lesion, whereas MS, it's a short lesion. The eyes tell you in many cases. Patients won't tell you necessarily they've had problems with their eyes, like optic neuritis, but they may say, well, I don't see red things as well with this particular eye, suggestive that indeed there has been a previous attack, like an optic neuritis. So what I do is I take all of those things, and I just kind of put them into a column, and I say, check, 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 check. And if somebody has none of those, or they're all skewed against multiple sclerosis, you can feel fairly comfortable that this is transverse myelitis not going to convert, not 100%, but you can feel pretty comfortable that the risk is a few percent. If you got all those things, it's so high a percent that you would probably start treating for MS even at that point. So it's really a conversation that's got to kind of aggregate all that data together and make the decision. Triggered.
And I work with children from age of 1 month onwards. And my 3 years old ADEM can tell me exactly where it has got a problem, what he can't do, what he can do, what he wants to do. Through games, you can achieve awful lot from the children. And they have incredible understanding if you just give them some understanding that what you want to work with through play. They are fantastic. They can actually now know 3 years old can put his electrode and get his FES working. He knows exactly where to put it. And when his mom doesn't get it right, he says, look, this is not right place. So children can learn awful lot. They can learn how to play through games that you can just create to do balance, you could create to do sensation. I have loads of variety of brushes, so if I brush their legs and they don't respond, you know they can't feel. So you give them brushes and they learn to brush variety of shapes, things that they can then learn from it, that they don't feel it, so they can use it again and again. So through games, you can communicate with children from age of 1 with no trouble.
I totally agree. I really enjoy watching my pediatric neurology colleagues do a physical exam on kids in their clinic, because it looks like they're just playing with those kids.
Absolutely.
They're not examining them the way you get examined as an adult.
Absolutely.
They're chasing after balls down the hallway. They're playing, all kinds of card games to see what they can see.
Now you know why I became a pediatric neurologist. It's fun to take care of pediatric patients.
Absolutely, it's fun. And they are incredibly aware and they can communicate with you. You just have to create the game that is exciting. And through that game, you can create their mind even to work. You can even work with them on creative visualization, that how they're going to get better. So through stories, through games, you can achieve wonderful amount.
And it does raise...
And may I say something
Yeah,
else?
please.
In London, we have Association of Physiotherapists interested in neurological condition. So if you go on a website, the Association of Physiotherapists interested in neurological condition. And I'm sure it could be just patchy and maybe they're not as normal as your orthopedic physiotherapist. But there are physiotherapists interested in neurological conditions. And that's what all of you should aim to get, rather than your own.
Ma'am, I didn't catch. Are you a child life specialist or a physical therapist?
I'm a neurophysiotherapist interested in children and adults.
Okay. I was actually, she sounded actually like she was describing what's called a child life therapist, and I know that Daniel has a bunch of these on his unit, but the child life therapist oftentimes can, if the physical therapist doesn't necessarily do this, oftentimes they do, a child life therapist can do these same sorts of things. So for the parents out there, a child life therapist can help you with getting the children to understand the therapies and to participate in the therapies that you know, maybe the pediatric physical therapist can't necessarily get the message across.
So to change it up a little bit and to increase the age of the child, though, so for our 8 to 16-year-olds, which is a different beast than the 2, 3, and 4-year-olds, one of the things we run into, and I'm curious for Greg and Daniel and Janet, getting our kids to do the therapy without it being mom and dad nagging all the time, or trying to take it from being a fight about it to motivating. Any words of wisdom?
May I say something? It's got to be the therapy's got to be age appropriate. So if you're working with somebody 8 years old, you have to find out what is interested for them, what makes them tick. So if you find out what makes them tick, it's really easy to motivate them to do the things, to do their therapy. Because then they are ticked.
Yeah, so some of my 12-year-olds will say, what motivates me is not going to therapy today.
Well, that's fine. That's also is acceptable because they can't reject that.
Yeah?
Yes.
Did everyone hear that?
No, I
Yeah.
For every minute of therapy you get so many text messaging privileges, and then
Or your Nintendo DS. That's another thing that motivates them.
you can use the Nintendo while they're standing on a balance board.
Yeah.
So
Jan-
why not combine it?
You know, the old Wehab too, that we're using a lot now too, with the Wii game, and our therapists use the Wii Fit, the balance board, and I'm
Yes.
always amazed, you know, you don't have to stand on that thing. You can sit on it and work trunk balance, and they do all kinds of things with the Wii too.
Why not use those games?
Absolutely, yeah.
And it's perfectly done, and it works, and it's age appropriate, and it's not exercise oriented. When the child becomes exercise, is physical, and you got to do it, meaningless.
Yeah.
Learn how to get there or what to do. So if you, they're happy to do it.
And it does get
Scooter
hard,
is even fine.
you know, at different developmental stages, you know, therapy to get things out of children, like she says, you know, we see kids, you know, when they're 2 years old, and it's really hard to get a 2-year-old to cooperate, but you do what you can do, and then the next time you see them when they're 3, they're a lot more interested, and they're a lot more cooperative. So, you know, it just goes in phases, and then it goes in phases of whether kids are willing to cooperate with their families. You know, my daughter, if I had to try and get her to do therapy, would be miserable. I mean, you know, it would just be really hard. So you have to do different things, like you say, text messaging, or, you know, we do charts with kids and, you know, reward stuff, and it doesn't have to be, you know, $50 or anything, just little things. And my mother had her hip replaced, and, you know, she's 75, and she called me up. She was doing therapy just to get her leg straight, and this just cracked me up. She called me up and she said, I got all gold stars this week in therapy. And I just started laughing, because it was like, my mom, she got gold stars, and she was so excited. She was telling me that because she was making progress with getting her leg straight after her knee was replaced. And I thought, rewards work for everybody, and it doesn't have to be expensive or anything. So just things like that you can use with kids to help motivate them.
Kind of along those lines, I'm a physical therapy student up in Washington, and one of the projects I'm kind of working on right now under a few different PIs is there's Microsoft just around the corner making the Xbox and whatnot, and they're making games where you can put electrodes on kids with CP and all that kind of stuff, where they can activate and play on the screen by activating certain muscles in their body. So it's a lot more fun to play Xbox by trying to activate your hamstring muscles or anything, you know, that's flaccid or tight or spastic or relaxing certain muscles. You can actually move the characters on the screen. And that's just a really cool project we're working on. It's not done right now, so don't call Microsoft and be like, where's this game?
Yeah.
But it's in process, so
That's
there's cool
great.
stuff happening. Yeah.
it's you know, so it's the next wave of biofeedback, basically. So
Right.
are you guys familiar with biofeedback? You try and do a motion, and you would watch just a little line on the graph and try and get it to move. Xbox is going to be way more fun than the line.